2025 Chinese focused on bone metastases. ESMO 2025 Chinese Researchers Voice to the World project. The forum is supported by Beijing by inviting international speakers. We aim to promptly share the highlights of the ESMO Congress, continuously enhance academic influence in the field of bone metastases in China, introduce China's academic achievements to more international peers, share Chinese experience, and explore disease management models suited to Chinese characteristics, as well as the latest concepts in the prevention and treatment of bone metastases. I saw that this conference has invited Professor Patrick Neven from the University Hospital Leuven in Belgium and Professor Olaf Stens from the University of Tübingen Medical School in Germany, both of whom are the members of ESMO Steering Committee. And in addition to the two ESMO speakers, we also invited Professor Fan Ying from the Cancer Hospital of the Chinese Academy of Medical Sciences and Professor Zheng Yingduo from CNSA Memorial Hospital and to join the discussion. And now, and also I am a medical oncologist from Fudan University Shanghai Cancer Center. And also I conduct some phase 1 clinical trials. And now I will begin the official agenda. I would like to invite the first speaker, Professor Patrick Neven from the University of Hospital Leuven, to start his presentation. The title of his talk is Early Diagnosis and Comprehensive Management of Breast Cancer Bone Metastases. Allow me to introduce Professor Patrick. He is a professor from of the Gynecological Oncology. Also is LKIKU Leuven Cancer Institute, a great professor, I think. So let's welcome, please.
Thank you so much for this invitation. Professor Zhang, I will now try to share my slides. So it's my pleasure to be here and to give you some recent disclosures on breast cancer bone metastatic disease. Here are my disclosures. And we talk about breast cancer in general, but the estrogen receptor positive breast cancers, when they metastasize, are a bit more likely to go to the bone than the estrogen receptor negative breast cancer. So breast cancer incidence has increased over the last decades, and patients with breast cancer, they do live longer, and we are able to prolong the disease-free survival period. So we will see more and more patients that we have to manage with metastatic disease, and it's as such that this metastatic disease might come back in up to 30% of the patients with early breast cancer. And if it's metastasized, about 70 to 80% is in the bone. Very few patients in Belgium are de novo metastatic. And also there, if that's the case, then it's more likely in the bone than in the liver or in the lung. But indeed, sometimes it's on different organs. So what we try to learn today is the current status, like epidemiology, the disease burden, early identification and assessment, prevention, treatment strategies, and I hope we will have a nice discussion. So bone is a frequent site for breast cancer metastasis. Tumor cells colonize the bone microenvironment. It can be in a dormant state, it can be in a symptomatic status. There is bone destruction, it can be mixed, it can be osteolytic, it can be osteoblastic. So the tumor microenvironment the primary tumor contains cells like hematopoietic stem cells surrounding stromal cells, extracellular matrix that interact dynamically, influencing the cancer cells for their invasion and metastatic potential. Otherwise, the bone is a micro environment that is very fertile, and they call it the soil and seed. So the bone is the soil, promoting cancer growth. So the seed and soil hypothesis, already mentioned by Sir Paget ages ago, describes how cancer cells exploit the bone that's made compatible for the cell to attack the bone, and the bone marrow microenvironment contains mesenchymal stromal cells, providing signals that can support this growth and then lead to considerable morbidity like skeletal related events, pain, fractures, impairment of quality of life. And there is a lot of knowledge about the pathophysiology, which are the growth factors, which are the cytokines that are produced in this microenvironment to make bone metastatic disease potential. There is a major role of osteoclastic function being driven by the rank and the rank L interaction on the osteoblast, on the osteoclast precursors. And that's the pathophysiology where we can interfere with bone metastatic disease prevention, but also treatment. So metastatic disease from the breast is very often osteolytic, but can be osteoblastic or can be mixed. So what as clinicians can we do? This is a 25 years old paper in Cancer when we didn't have these treatment opportunities and where the disease appeared earlier. And 25 years ago, prior to bone targeting treatments, 1 year after a patient presented with bone metastatic disease, the median time to the first skeletal related event was about 7 months, and patients now have a doubling median OS. So we are confronted with patients more likely to have bone metastatic disease. So we need to control the disease. Otherwise, we will have fractures. The need for radiotherapy is very high. Hypercalcemia that we very unlikely see today in the clinic. We have less orthopedic surgery. We have less, but it still happens, spinal cord compression. So this is really a very important topic when we talk about breast cancer management, not only for treating bone mets, also for prevention of bone mets. If it's already in the metastatic disease, current bone agents that target these osteolytic osteoclasts, just putting them at rest, they inhibit tumor-associated osteolysis, pain, and they prevent hypercalcemia, pathological fractures, and spinal cord compression. Together with radiotherapy, orthopedic surgery, palliative care, and there we have two main drugs. There are several other treatments, but we will focus on the bisphosphonates and on the denosumab, which is a monoclonal antibody against the rank, and that leads to inhibition of the osteoclast. So we have two drugs that have been compared, one with the other, and it seems from these randomized controlled trials that denosumab is a little bit more favorable than zoledronic acid, 17% less time to the first skeletal event, 18 for the subsequent skeletal related event. And so it delays these skeletal events more and better than the zoledronic acid does. But the overall survival, comparing one with the other, is not better. But we seem to be more able to control this bone metastatic disease based on all these skeletal related events, hypercalcemia, fractures, and spinal cord compression, including the time to radiotherapy, the time to orthopedic surgery. There are ESMO guidelines that have lastly been updated in Annals of Oncology 2020, and that's where you can see these guidelines. Regarding side effects, there is a difference. You know that zoledronic acid can only be prescribed if the kidney function is normal. There are other side effects, and we always wonder if there is less osteonecrosis of the jaw, which is the most important side effect, because this on its own leads to palliative care and patients can die of it. So this is what we have to avoid. We have risk factors. We have two potential good drugs with a similar efficacy, but both of these drugs can induce ONG. So hypocalcemia, skin infections, hypersensitivity, renal toxicity. It can be induced by bisphosphonates. Acute face reactions by giving the infusion versus the subcutaneous injection. So these drugs are different regarding to side effects. But, we have them for a long time. We know these drugs. We can see the patients with particular risk factors. And then we have to choose between one or the other drug based on the individual risk to develop such ONG risk factors. So what about patients with early breast cancer? Do we have tests to screen for bone lesions? We don't screen for bone lesions in patients with early breast cancer. We do assess the bone if patients have symptoms. In my country, we still do a lot of biomarker assessment in patients who have been treated for early breast cancer. We do measure CA 15.3 on a quite regular basis. Of course, 5 years out of the disease, we do it only yearly by the general practitioner. And if there is a signal that it might be a patient who has progressed, we in Leuven prefer doing PET-CT rather than bone scintigraphy. We also have developed a very sensitive test, which is called the whole body MRI, where if patients have lobular breast cancer, we do believe that this is the best way of detecting metastatic lesions in lobular breast cancer. So, but we now have very good tests to detect very early on these patients. We don't look for bone relapses that are biomarker driven, like tumor cells or circulating tumor DNA. But we do participate in such studies where if the patient might develop not anatomical progression, but molecular progression, interfering a bit earlier to prevent metastatic events, these are ongoing trials also in our institution. Also here, we have drugs available, and these are actually the same drugs that have been tested in clinical practice in patients with high risk early breast cancer, also in patients with triple negative breast cancer. And there we have had 20 years ago very many trials comparing zoledronic acid with placebo, denosumab with placebo. And the consensus today is that if patients have high risk to relapse early breast cancer, that we do advise adjuvant bisphosphonates or adjuvant denosumab. In my country, these drugs are not reimbursed because they don't have the FDA label, but we have these drugs. So we are driven by patients who are been given anti-hormone treatment, where we know that the bone might become more fragile. So we do a DEXA scan, and if the patients are osteopenic or osteoporotic, we can give these drugs. We have oral bisphosphonates, alendronate. We have zoledronic acid, 4 milligram, 5 milligram, which is reimbursed yearly if there is osteoporosis. So we have cheaper drugs that we give the patients at high risk. There is absolutely also a place for denosumab, and in other countries, but not in my country, this drug is used based on the studies that have been done. I refer to the study published in the New England Journal of Medicine, where denosumab was given every 6 months on a regular basis in high-risk patients, and this clearly met the initial primary endpoint that was favorable. But we, in my country, we rather give bisphosphonates. Also, if you give this lower dose less frequently, there is less ONG, but we can come back on that later. So here I have copied for you this clinical guideline, how to deal with patients and having metastatic bone lesions, the first line of treatment, second line of treatment, and progression. And this is something that has been published in Nature Reviews Disease Primers by Professor Coleman from Sheffield. And part of my presentation, I have asked him to present some of his slides, and that is one of his slides. So you can look into it, and what you see is, depending on the symptoms, depending on the number of bone lesions, and we also in Leuven de-escalate the monthly zoledronic acid to the 3 monthly if patients achieve disease control on systemic treatment. So that's the schedule that we do use in the hospital. So this is the first part of my short presentation. The second part is on some recent disclosures from ESMO meetings. And this one is from an Italian group where they have compared long-term treatment with either denosumab or zoledronic acid, real-world retrospective observational data, where the endpoint was time to skeletal-related events, pain, based on the use of oral morphine expressed as OME, based on the WHO pain scale. And what they did is they assessed the occurrence of skeletal-related events, the use of bone radiotherapy, bone surgery, comparing patients who were either on zoledronic acid or denosumab, and they concluded a comparable effect on the appearance of the first skeletal-related event, and also on the need for local treatment. This was similar. What was different was that patients on denosumab were 89% less likely to increase one step on the WHO pain ladder, that there was a reduction on the average of the numerical rating scale for pain intensity using denosumab, and also the time to reach the oral morphine equivalent based on the model need for morphine was improved with denosumab over zoledronic acid. And you can see these curves here. On the left, you can see this scale for the pain frequency and intensity. And on the right, you can see the dose of morphine equivalent comparing in red zoledronic acid with denosumab. So there seems to be a difference, but also not a difference that was reporting to time to radiotherapy. But this is clearly that these drugs have been compared with each other, and I thought this was a nice disclosure from ESMO. Another disclosure is from Leicester University Hospital, where they looked to patients with early and patients with metastatic breast cancer that were using either zoledronic acid or denosumab, but patients were able to switch from one to the other. And you can see the number of the patients that they included in this retrospective study, 455 patients. The majority were stage 4, and they looked into osteonecrosis of the jaw that was likely related to any of these two medications. So patients could not have a history of radiotherapy to the jaws. They needed to have one or the other drug. And then you can see in figure 2 that the medication-related osteonecrosis of the jaw was only appearing in 3.7% of the patients treated in this hospital between 2015 and 2020, based on these retrospective data. And the majority of these patients that they had with this ONG had risk factors, and these risk factors, as you all know, was a dental intervention. They also looked to the place where this ONG was reported, and this was most likely in the mandibula more than in the maxilla. And also concurrent use, none of these patients were using bevacizumab, which is a risk factor. None of these patients were used corticosteroids, which is also a risk factor, but you can see that some of these patients who did develop ONG were concurrently on CDK4/6 inhibition, anti-hormone treatment. But dental intervention clearly is a risk factor, and you can also see other potential risk factors like diabetes, hypocalcemia, and current smoking. So this is rare, but we have to be aware of this potential side effect. The third of the 4 disclosures is this one from Italy, from the Gemelli Hospital in Rome, where these colleagues, in a very small cohort of important patients, so perimenopausal patients with high-risk early breast cancer, and the median age was 45, 88.4% were under age 50, also retrospectively collected between September 2018 and January 2025, all receiving adjuvant endocrine treatment and bone protection with denosumab, given to protect the bone, looking into all these potential risk factors, BMI, tumor stage, vitamin D levels, smoking or not smoking, comorbidities, and that they here report the results that denosumab, concurrently given with endocrine treatment, is very efficient in preventing osteoporosis, reducing bone turnover, and improving the bone density with an excellent adherence. And so this is what they do in Italy and also in other centers. They do give denosumab for prevention, and we would also advise it absolutely if the patient has osteoporosis. Otherwise, we give the drugs that are less expensive, like oral alendronate on a weekly basis. The last disclosure that I believe was interesting to mention is that denosumab is being considered in a study to prevent breast cancer, and the study is called BRCA.P, so it's a prevention trial. Christian Singer from Austria is the principal investigator to prevent breast cancer by inhibiting RANKL signaling. And based on this trial, I was looking for experiences in the world. How can denosumab delay or control disease if you have bone metastatic breast cancer? So what they did is they looked into thousands of patients with ER-positive, HER2-negative breast cancer treated with CDK4/6 inhibition. They selected the patients, 1,399, with bone metastatic disease treated with CDK4/6 inhibition, so quite recently treated patients, and they traced retrospectively 46 patients with a germline BRCA1 or BRCA2 mutation. Of course, these are very small groups, but they were looking with the Kaplan-Meier curve if patients who were on or patients who were not on denosumab had an effect on the response on treatment. And what they did conclude was that patients who had the mutation treated with denosumab had a longer real-world PFS compared with patients who didn't have denosumab. So this was quite impressive, And the study does suggest that denosumab administration in the BRCA1/2 mutated ER-positive HER2-negative breast cancer with CDK4/6 and endocrine treatment has an improvement in the real world median PFS if you treat this patient with denosumab as a bone agent as compared to the group with no denosumab. This has not been published, but this was presented recently during ESMO Breast. So to conclude, we now have one clinical case that we recently had in UZ Leuven. This was a young patient because I do believe that the patients in China are much more likely to have breast cancer at an earlier age than we have in Belgium. So this was a perimenopausal 40 years young patient with a PT2N1, primary surgery, white excision with sentinel lymph node procedure, and this was clinical node negative, but it turned out to be pathological node positive with one positive lymph node and high-grade lesion, mama print. So the gene expression profile was high risk, and she had ovarian function suppression with chemo. And then we continued on ovarian function suppression and letrozole. She had, at the start, a DEXA scan with a lab checkup that we always do to check the bone metabolism. And this patient was not frail, but very often we give vitamin D and calcium supplementation. And we decided to give this patient who did not have osteoporosis, neither osteopenia. We did start her on prevention, and we did give her the choice, because her renal function was normal, between zoledronic acid once every 6 months, like in Zofast, or to give weekly oral alendronate. And my guess is that based on the Austrian breast cancer study group, denosumab is a good alternative for this patient. So to conclude, bone-targeted treatments significantly reduce skeletal-related events in patients with bone mets and should be part of the standard treatment. They should be continued throughout the course of the disease. There are good data, head-to-head comparison, that denosumab for some endpoints is more efficacious for the prevention of skeletal-related events and fracture prevention based on these trials. Low frequency administration of any of these drugs, what we use with zoledronic acid, is de-escalating after 1 year to the 3 monthly application instead of the monthly. That might need evaluation in good prognosis patients. There was recently a disclosure in the New England Journal of Medicine that it might be useful, but this is just to treat osteoporosis every 18 months instead of every 6 months. So maybe we are overdosing these patients. Bone protection reduces metastasis to the bone. It improves survival, and it prevents osteoporosis and fragility fractures. And we do bisphosphonate. We do give bisphosphonate as an adjuvant treatment in postmenopausal patients with a high risk. And if we do give denosumab, we always give, if we stop denosumab, 1 infusion of zoledronic acid, because otherwise we see this rebound effect. And this is my last slide. So thank you for your attention. I will stop sharing my slides.
Okay, thank you very much, Professor Patrick, for your excellent presentation. I think your speech has given us a complete new understanding of breast cancer bone metastasis, while also highlighting the importance of comprehensive diagnosis and treatment, especially for the uses of the adenosine acid and zenotuzumab. And I think this approach not only improves the quality of life, but also enhances survival outcome. Okay, now let us warmly welcome the second speaker, Professor Anna Stans from University of Tübingen Medical School. He will deliver a presentation titled uh, Bone Protection and Long-Term Management in Prostate Cancer with Bone Metastasis. We're also very much looking forward to your insights. And let me introduce Professor Anna Stender. He is also from the University of Tübingen Medical School, and he's a director of Emeritus of Department of Urology and a senior professor at the university, and is Secretary General of the European Association of EAU from 2023, and also President of the German Association of Urology, and is Chairman of the Scientific Congress Office of the European Association of Urology, and a lot of honorary presents of some society. And let's welcome. Please begin your speech, please.
Ni hao. Thank you very much for this
Great.
invitation. And thank you for being able to be here. And my goal was to, well, the first goal was to get to the presentation. Okay, let me. And can you see and hear me?
Now we cannot
Not
see
yet.
screen, see the PPT.
I did. You cannot see my screen?
Yes.
Okay, I maybe the back office can help us because I have okay. The screen sharing has been interrupted. I don't know why.
So maybe you can try this again. So
Yeah. Let me see.
okay,
Uh,
you can see it.
okay. Okay. Maybe my finger was too fast. Okay, so thank you very much. And my goal is to talk a little bit about the bone protection and management of prostate cancer with regarding to the bone and bone metastasis. Um, Several things are similar to what Professor Navin has shown for breast cancer, and I cannot advance. Okay, these are my conflicts of interest. Um, but in especially in prostate cancer, and probably in prostate cancers than most of the other tumors, bone plays in the advanced stage a very important role, and the likelihood of advanced, especially castration-resistant prostate cancer, to get bone metastasis is very, very high, as you can see here, compared to other cancers. And if we look at the overall incidence of prostate cancer, then those that are actually get bone metastasis is already somewhere in the range of 15-20%. And those of the advanced prostate cancer, then about 90% do get bone metastasis, and this is especially those patients that die from prostate cancer are most likely, if detected or undetected, have about 100% incidence of metastasis or tumor cells in the bone system. Now, the extent of bone lesions is associated with an increased mortality, as you can see here, and it's the number of bone lesions that also increases mortality. So that is one of the reasons why we fear bone metastasis in patients with prostate cancer. And the recent advent of better imaging of patients with prostate cancer with the help of PSMA PET CT showed that we do have not only sometimes a downstaging, but especially an upstaging in quite a number of patients, which then influences us in our management of the treatment of advanced or metastatic disease. And that is one of the reasons why we see more bone metastasis now and metastasis in general, but that also shows us that what we previously had seen as a high-risk non-metastatic disease now becomes a low-volume metastatic disease, showing us that on the one hand, what we treated initially as a non-metastatic disease is actually a metastatic disease, and if we detect now with the new imaging possibilities a low-stage metastatic disease, low-volume metastatic disease, this may be similar in with the high-risk non-metastatic disease. But of course, if a patient develops bone metastasis, depending on the location of the bone metastasis, then almost all patients do experience some form of bone complications, starting from pain, starting from impairment of movement, to fractures. And that is especially when it gets to the spinal cord compression and fractures of the spinal cord. That is appearing in approximately 8% of all patients with bone metastasis due to prostate cancer. And that is a terrible situation for the patient, being bedridden or cannot move apart from enormous pain. Sometimes that leads to an enormous problem, not only for the patients, but for the health care system, because these patients need a lot of resources for their treatment and especially for their symptomatic treatment. And of course, as already previously said, any bone metastasis, especially then in a severe location like the spinal cord, will then decrease life expectancy. And it is also clear that we could do what we could do is we could treat the bone metastasis. But of course, there is an improvement sometimes, in some cases, especially in the oligometastatic disease, if you do a metastasis-directed therapy. But the actual advantage of treating the bone metastasis is quite low. Higher is the effect of the treatment of low volume, again, low volume oligometastatic disease when you treat the primary treatment, and the HORAD and trial have shown that this treatment of the primary in the oligometastatic disease is beneficial with regards to overall survival. And the earliest treatment of bone metastasis in an isolated form was the ALSYMPCA trial, looking at radium-223 as a possibility of treating bone metastasis. And at that time, it was the only or the best way of treating the bone metastasis by nuclear medical form of treatment. And you can see here there was a survival benefit simply in by treating bone metastasis. And even more so, it was possible to show that the first symptomatic skeletal event, any of those from pain to fracture as a worst form, it did show that it could delay that and it could improve, of course, then um, not only the patient's symptoms and the patient's problems, but also the resources of the healthcare system, again, if patients did not develop fractures. And how do we know that that we do any benefit to the treatment of bone metastasis, not only by imaging but also by bone markers such as alkaline phosphatase, and the bone-specific alkaline phosphatase did show in the Al-Simca trial in the uh, in the comparison group, control group, that the um, the alkaline phosphatase, even in the untreated, did show a correlation with the overall survival. So in other words, alkaline phosphatase, especially the bone-specific alkaline phosphatase, is a valuable bone marker or biomarker for the fate and the activity of bone metastasis. Now, bone-targeted therapy overall does show a survival benefit. Saad has shown that several years ago that if you look at the bone targeted therapy versus no bone targeted therapy, there was a difference between the two. So the survival overall does show a benefit, and that may be with systemic therapy as well as regarding to the bone-specific radium-223 treatment. And if you look at the type of metastasis, or the type of bone metastasis being either osteoplastic or osteolytic or mixed, then especially in the prostate, probably more than in the breast cancers, you've just been shown that it is mainly osteoplastic and the prevalence being very high, as already mentioned before. And that means also that we have to look at the bone microenvironment and trying to see how their bone metastasis can be prevented. And the rank ligand being one of the preventing targets of bone metastasis has been investigated several years or decades before and shown that this rank ligand inhibitor may then really increase the survival without bone metastasis as a prevention of developing bone metastasis because of the interruption between the rank ligand and those tumor cells that increase the osteoclasts and therefore or inhibit osteoplastic formation, thereby then leading to the osteoplastic metastasis. And also it has shown that apparently the primary treatment, the primary identification of clonal prostate cancer cells will then eventually lead or inhibit the development of bone metastasis and its increase in the entire bone system. But rank and rank ligands not only occur in the entire in the bone, but also in other organs or systems of the bone and lymph nodes and other organs do play a role. So we may think that some of the RANK ligand inhibitors may help in getting the entire body involvement of prostate cancer metastasis then influenced. But again, work in progress, and is that rank ligand is a mediator for osteoclast formation and function and survival in bone metastasis. And denosumab, as also previously mentioned, not only for prostate cancer, but for other tumors, of course, given in a monthly dose every 4 weeks, does lead to a prevention of the skeletal-related events, SRE, and it has been approved in Germany and, to my knowledge, in Europe and other parts of the world for the treatment of prostate cancer-related, skeletal-related events. And what happens here is that the denosumab binds as a monoclonal antibody to human rank ligands, and so thus it prevents the rank ligand from activating the receptor rank, and thus the stimulation of osteoclasts. Now, we have been talking about survival, overall survival. And of course, in metastatic castration-resistant prostate cancer, we try to increase the overall survival. But overall survival does not always mean that we really improve the quality of life for the increased survival period. And so it must be our aim, and that is why it is important to think about the symptomatic relief of bone metastasis by thus increasing also not only overall survival, but also the quality of life of these patients. And that means, for example, that the time to opioid use, the time to treat severe pain with bone-targeted therapy is really prolonged. Saying, in other words, you can defer the opioid use of bone metastasis with the help of bone-targeted therapy. Let me get to a case, fairly young case, a couple of years ago, who was shown with an increase in PSA, and thus an MRI was done, as it's now in the guidelines of the both the European and the German guidelines before you go ahead and do a biopsy. And already it was seen that not only his PSA was elevated and that there was a suspicious lesion in the prostate, but also there was an osteoplastic bone metastasis in the right superior pubic ramus. A single metastasis, bone metastasis. So it is an oligometastatic disease. And of course, now we do have access, and in Germany, actually, for 10 to 15 years, PET-CT with previously with glucose tracer, and later on with a colon tracer, and more recently with the PSMA tracer was available. And it showed there was no lymph nodes in this gentleman. The PSMA overexpression in the right lobe of the prostate, as you can see here, but the PSMA positive lesion in the right pubic ramus. Single metastasis. Yeah, what should we do? Shall we do just give him a hormonal therapy. That what we would have probably done 10 years ago. Should we radiate the prostate and hormonal therapy? Should metastasis directed treatment? And should we be radical and do a radical prostatectomy and radiation to the bone, and with or without ADT? The current guidelines would recommend it's an oligometastatic disease, so you can think about radiation of the prostate, and you would probably do an hormonal therapy plus a new androgen receptor inhibitor, and that is something that could be done. Of course, you could think in a very young patients, even in not only doing a local therapy with radiation to the prostate and double hormonal therapy, but also then maybe do a metastasis-directed therapy, especially if it's symptomatic. Then it would be something that the guidelines would support it. If not, then it is a very individual therapy and not guideline directed, but it could be done. And actually, to be honest, it has been done like that. And with that, the patients remained non in under hormonal therapy. He had no PSA. The PSA was non-measurable. So guidelines, yes, they have changed, treating in the primary organ and also the hormonal therapy. But individually, of course, you could go ahead and do the thing. This is a very busy slide. It is the what is currently used in prostate cancer with bone metastasis. Yes, vitamin D and calcium supplementation. Don't forget about that. Also, exercise, it helps. Anti-resorptive therapy, it's approved in Germany, zoledronic acid, given 4 weekly, but there are data now that it may be given, as my previous speaker has already said, over treatment. If you give it monthly, it could be given every 3 months. Denosumab every 4 weeks in a dosage of 120 milligrams. Both denosumab and zoledronic acid do reduce the skeletal-related events in metastatic bone metastatic castration-resistant prostate cancer. However, there's no sign that it does actually improve overall survival. The radium-223 for symptomatic bone metastasis in metastatic CRPC is still an option. Despite the ligand therapy. I didn't go into ligand therapy because it's not a particular bone related treatment. Patients that do get a hormonal ablation therapy, the use of denosumab at half dosage, 60 milligrams, we call it Prolia, every 6 months, increases the bone mineral density. We think that patients that are on hormonal ablation therapy for prostate cancer, they lose the bone density by 4% every year of the hormonal therapy, and that's why denosumab may be helpful here. And denosumab, as I said, again, together with, not together, or zoledronic acid, may be used on a 4 weekly basis. Zoledronic acid may be only at 3 months incidence. Think about the renal function and the fact that it should be given in an infusion minimum 15 minutes. Better, I always do it infusion. And Again, like in breast cancer, when discontinuing anti-resorptive therapy, we have to be careful about a rebound bone resorption. So in short, the bone-targeted agents, bisphosphonate and denosumab, are approved and should be applied. Supplementation with calcium and vitamin D, together with exercise, by the way, is a way of bone prevention, bone health prevention, radiotherapy for symptomatic control. In a single bone metastasis, to be discussed as a treatment form in the oligometastatic disease, surgical interventions when indicated only for symptomatic reasons, and the monitoring for the side effects, osteonecrosis of the jaw and hypocalcemia, are basically every patient should be seen by a dentist or maxillodentist specialist, maxillofacial surgeon specialist for seeing if there is any possible risk factors, and anything that is done which the dentist you does, which leads to bleeding. I always put it very simple. That should be avoided under the treatment of biphosphonates and denosumab. So this is just in short what relates to the bone metastasis and bone health in bone metastatic advanced prostate cancer. Thank you very much for your attention.
It's great. And thank you, Professor N.F. Stans. And I think if a presentation on the prostate cancer with bone metastasis is very great, and we teach us a lot. I believe that why bone metastasis in the breast cancer we just talked about, and this breast cancer have distinct characteristics. They can be addressed through similar intervention approaches, and also use something drugs, we can improve the quality of life and overall survival. Now let us move into the panel discussion session. In addition to the two speakers we just heard from, I would like to invite two more Chinese experts to join this discussion. Professor Fan Ying from the Cancer Hospital of the Chinese Academy of Medical Sciences. She is also chief physician, a master supervisor, PhD, and also the visiting scholar at the Royal Mason Hospital. And she is a vice chairman of the Secretary General of Clinical Research Committee, China Medical Education, and he has also had a lot of titles. And the second professor is Professor Zheng Yingduo from Yasen Memorial Hospital, and she's from the Department of Breast Medical Oncology, and she's also the chairman of the Breast Medical Oncology Committee from Guangdong Thoracic Tumor Prevention and Treatment Research Society, and also have a lot of titles. And let's begin with the first topic. We have 4 topics. The first topic is, do you decide the timing and the duration of bone-targeted drugs used based on whether the patient has bone pain? I think the two professors focused on breast cancer and prostate cancer maybe have different ideas, and also could you share your vision? Firstly, Professor, maybe from breast cancer first. The first professor, Patrick.
Thank you. So in Leuven, we are very eager to start early on once we see a bone metastatic lesion, also in asymptomatic patients. If, however, we have oligometastatic disease with one lesion that might be picked up by a asymptomatic increase in the tumor marker, and this patient has S, B, or T, so radiotherapy, and she doesn't develop other lesions, then we are quite eager to stop this drug and to keep it for if the patient might develop pain. Otherwise, in some of these patients, we might have to go on for a very long time. However, if the patient has early breast cancer, we give it for 3 or 5 years. If the patient copes well with the agent, because some patients do have side effects, like flu-like side effects, infusion reaction side effects with zoledronic acid. There we only have bisphosphonates, and in the early disease, we don't have denosumab available in Belgium. So there we give it only for a couple of years. Yes, so it depends on the number of bone lesions, on the early or late stage of the disease. So it's really based patient by patient that we discuss it. Yes.
Okay, it's great. Case by case, I get the meaning. That means we decide the patients for early or breast cancers are different situations and also a lot of factors that influence duration timing. Thank you. And Professor on Anaf, could you provide some experience for the prostate cancer?
Well, thank you, Professor Chen Chang. In prostate cancer, let's put it like that. If the patient has a hormonal therapy for more than 6 months, then a low dose bone prevention is advised. What does that mean? That is either zoledronic acid in larger intervals, 3 months, 6 months, or denosumab in a low dose, half dose, 60 milligrams every 6 months as an injection. Now, which one should be given? Personally, I prefer denosumab to zoledronic acid because in the age range, which we have in prostate cancer, up to 50%, 50, do have an impaired renal function. And therefore, you would rather decide to have denosumab, which is not only easier to apply, but also would not interfere with a decreased renal function. Now, in what about symptomatic or non-symptomatic? Definitely, there is no question symptomatic patients should have a bone protective drug. And in the case of non-symptomatic, it really depends on, first of all, the type of treatment the patient gets primarily. Does he get a doublet? Does he get chemotherapy in addition, triplet therapy? But also the amount of burden in the bone. So if you have a multi metastatic polymetastatic disease with many. I know definition of many, but if you have a high to volume, then definitely he would even get it without any symptoms, any drugs, and that again would be denosumab on a monthly basis and zoledronic acid usually on a monthly basis. Of course, there is always the question whether it could be given every 3 months for obvious reasons, because also side effects could be less severe or less frequent. How long? Difficult. Some studies have argued that you could stop it after 2 to 3 years. The jury is out on that, and gets very individual, and the guidelines really have a problem with making a recommendation here. End of statement.
Okay. That's great. I think breast cancer and prostate cancer is quite different, and that means zoledronic acid also Zoladex also can prevent a relapse of the early breast cancer. However, in breast cancer, maybe we did not have these results of, for breast cancer. Most we used this kind of drug, bone target drugs, just around metastatic setting. And Professor Annoff has told us a lot of information, and he also prescribed the this denosumab because of kidney and factors or others, and I think it's provide a lot of experience. And next, we invite Professor Fan Ying to share her experience. Please.
Thank you very much for your question. So I think for me, the answer to this question might be no, not only depend on whether the patient has bone pain or not. Of course, one important efficacy of bone modifying agent of course, is to relieve bone pain. But on one hand, the relief of bone pain is not solely on the use of bone target agents. More importantly is the effectiveness of anti-cancer treatment. On the other hand, I think the more important role of bone target agents is to reduce the skeletal-related events together with anti-cancer treatment. So for me, even if it is a symptomatic bone metastasis, as long as it is osteolytic bone destruction, I will initiate bone target agents as well. As for the time, how long to use the bone target agents, I agree with the two professors. It's quite tough. For me, in my clinical practice, I sometimes maintain the agent for at least half a year or 1 year. Then I will switch to 3 months treatment schedule. Maybe in some patients, because of the side effects or and something else, I might consider sometimes stop the agent, but not very often after 2 years. And I agree it is a case by case.
Okay, I think also we hear the case by case, a lot of information to decide whether we choose one or not, or the timing and duration. Thank you. And finally, we will invite Professor Zheng Yingduo, please.
Yeah, thank you for your question. And in my opinion, bone pain is not the decisive factor for determining the timing and duration of the bone BTA, because sometimes we detect the bone metastasis through the CT or MRI before they suffer from bone pain. I think we should recommend BTA treatment immediately after the diagnosis of bone metastasis. And for the duration, there are 3 professors. I agree with them, and the duration should depend on the side effects and whether the bone metastasis is stable or not. And I think another very important is depending on the age, because for some older patients and their tooth is not very well, and they have more chance to suffer from osteonecrosis of the jaw. And can I ask a question?
Yeah,
please. I'm very interested in the early detection of bone metastasis, and because in China, the medical insurance is very strict now, and for patients with a lymph node with positive lymph node, before many years ago, I will recommend to use a CT or MRI or ECT to detect whether they have bone metastasis. But now, in China, and the government recommend us to lower the expense of patients, lower the patient expense. So, for in my clinical experience, if the patient's lymph node is the number of lymph node is high, such as they have 9 or 10 lymph node, I will recommend CT or MRI or no. If the lymph node is positive, I will recommend CT. And how about in foreign countries? How many lymph node we recommend CT, MRI, or ECT for early detection of bone metastasis?
So if I can start, when you talk about breast cancer, I think it's a very interesting question. Also, in Belgium, in the past, let's say 20 years ago, these patients, high risk, had like once a year a CT scan or a bone scan, an ultrasound of the liver. Today, however, we don't search for metastatic lesions in patients who are asymptomatic because there is no survival benefit of treating metastatic disease earlier or till the patient has symptoms. However, in some subtypes of breast cancer, we now have better treatments than we have had ever before, like CDK4/6 inhibition, anti-HER2 treatments. We have immune treatment. So there might be a place for searching for metastatic disease, but so far we don't do it in Belgium, also not in a patient who has had 10 positive lymph nodes. So if a patient is oligometastatic and we can put her into a status that we can promise her that she is becoming cancer-free, then we will intend to do a 6-month PET-CT only once, unless the patient has symptoms. So we have some sort of algorithm how to follow these patients up. But if there is no metastatic lesion, we don't search for metastatic lesions in the follow-up. Thank you.
Thank you.
May I follow just one question?
Yeah, okay.
Okay, thanks. I want to ask Professor Nevin or Evan. I don't know how to pronounce this. So I don't understand because if we want to use bisphosphonates for prevention of bone metastasis in the adjuvant treatment of breast cancer, I think there are only evidence in hormone receptor positive HER2 negative breast cancer patients, especially post-menopausal patients. So I just don't understand why in ASCO guidelines it was recommended to all the subtype. I just don't know why.
Yes. So there are a couple of trials that did include patients with non-ER positive HER2 positive disease. And you are right, it's only working if patients are menopausal or if they are put into the menopausal status, if they were premenopausal. So if you give ovarian function suppression, the guidelines do advise prevention of bone mets by giving bone targeting agents. If the patient is ER negative or if the patient is HER2 positive, also in Leuven, we don't do it. But you're right, it's still in the guidelines. Correct.
Okay. Thank
Can I just get the aspect of prostate cancer in there? It's a little bit different because we don't have some of the features you have in breast cancer, but we have PSA and we have two warning signs, red lights popping up, and that is if the alkaline phosphatase is high, and the other one is that if there's any metastasis in the vertebral column, because that is 8% and these patients may have severe problems if they get a pathologic fracture or a discus prolapse, and they may be paralyzed without any problems. If regarding to the positive nodes, especially if we have severe signs or clinical signs as well as signs in histology and whatever, we do a PSMA PET CT. And that is, of course, then shows us with a high specificity, especially that there is bone metastasis or not. End of statement. I think you're muted, Professor Jiantang.
Okay, it's muted. I think it's a different topic for breast cancer and prostate cancer. And actually, we also used the BTA also in the adjuvant setting in the postmenopausal patients. However, we will still needed some also randomized studies for HER2 positive and triple-negative cancer. And also, the screening strategy is quite different. And the Professor Ying asked this question, and we got some new information from European countries. Thank you. Then when we talk after this discussion, we will move to the second one. The second one is in clinical practice, how do you prevent occurrence of osteonecrosis of the jaw? I will choose two experts from European and China to discuss this topic. The first maybe Asaf, please. Maybe can you first? Professor Stenzel?
Okay, okay. A very important question. Thank you very much for putting this up. 1 to 2% in prostate cancer patients on both zoledronic acid and denosumab been shown. There might be a little bit more in the denosumab patients, but that may also be to other reasons. The most important thing is they should be seen by a dental specialist before they start with the treatment on either one. And that is important. And then the other one, as I already mentioned, he has to be advised. I mean, we have leaflets that the patients have when they go to their dental specialist, that they bring it with them, and where everything is written about the type of bone prevention or bone treatment drugs they get, and that he is advised, very simple, don't do anything that bleeds to that patient during that treatment. If there is an important thing to be done, either before you start with the treatment, or then I would advise 3 months of a pause break before that can be done. And again, you know, as a urologist, it sounds funny, but I usually look into the mouth of the patients. Different hole. End of statement.
Okay, I think
I can maybe just add that we should sometimes be careful with corticosteroids, or sometimes in breast cancer we give bevacizumab, Avastin. So also this is a risk factor. Diabetes is a risk factor. Smoking, of course, but it's going all together with this toilet of the mouth. And, you know, sending these patients first to the dentist is very important. We in Leuven are very fortunate that we have a group of MKA specialists that really are looking into this very seriously. And this is a really dreadful disease, huh? And it's not always easy to prevent it, but if we can, we should.
Okay, do some prevention to lower the incidence of this ONJ. So I asked one of the professor from China, Professor Fan Ying, could you provide experience?
Yeah, I quite agree with two professors. I think one important thing is education. So tell the patients to see dentist before the application of bone modifying agents, and during the treatment of bone modifying agents, tell the patient that if they have some problems with the teeth, they must try to avoid the dental intervention. The operation like things like that. And another important thing I want to make a supplement is that to tell patients that if they have something discomfort in the teeth, must tell the doctor to tell us to remind the patient the possibility of osteonecrosis of the jaw, and if the dental intervention is a must-have, is a mandatory in my clinical practice, I will tell the patient to stop the BTA for at least I don't know how long in the Western professors. For me, maybe it should be interrupted for at least 3 to 6 months. Is that enough?
So time, maybe we 3 months, and
Or half a year?
Well, I generally would say 3 months, but it depends on really whether you do it without any symptoms, without any vertebral column metastasis. I would make it dependent on that. But Professor Yingfan, you're right. You can be flexible here, but 3 months is something I would advise mostly. I don't know how it's in breast cancer.
I agree. Nobody knows, but I think you should be very careful. We always discuss, and but as you mentioned, it starts when you have bleeding in the mouth. It's not just by extractions, but all interventions can lead to disasters.
Yes. So 3 months may be a good choice, but maybe we need some retrospective studies to find how many months is good. So ONG is real but serious risk associated with bone BTA. And thank you for advice. To proactive management is key to mitigation, and a comprehensive dental examination be completed before initiating therapy. Thank you. And we'll move to the topic 3. Topic 3 is what are the diagnostic methods for bone metastasis, and how is treatment response evaluated? I think Professor Zheng Yingde has asked some questions. So the screening strategy, and also I think she must have some experience about the diagnostic methods and how to evaluate it. Please.
Yeah, thank you. And in my clinical experience, and the ECT is and PET-CT is very sensitive. And if if it is normal, so I will recommend to use CT or MRI to confirm the bone metastasis. Can I ask questions? And for the second question, for the ONG, if patients suffered from the ONG and after they receive the careful treatment of ONG, and for some patients with very severe bone metastasis, and patients are very worried, they will ask whether they can resume their BTA. And how about in foreign countries, will you recommend them to rechallenge for patients with very severe bone metastasis?
Which
It's
one
a difficult
goes
question.
first? Who goes first? Well, a very good question. I mean, it needs a very good collaboration with the maxillofacial surgeon and with the dental specialist. And he needs to tell whether, in his opinion, the necrosis has subsided, has been treated sufficiently, and then you can go start. But it is not something I would dare to say that as a urologist or uro-oncologist. I would really have his or her opinion that the treatment has been finished and the healing has been complete. If you're doubting, not doubting, but if you want to be really careful, then you may start with not monthly denosumab, but like bi-monthly, 3 monthly. Yeah, be flexible here, and zoledronic acid, of course, then start with 3 months intervals. Even there is a drug that is half dose, 60 milligrams denosumab. Why not start with that one? Yeah. If you have that flexibility, that is what would be a thing. But again, if he has pain-related metastasis, or no, metastasis-related pain, then it is always the balance. Where do you achieve something with the risk of having another ONJ possibility? End of statement. But very good. Yeah.
I think it's an important question that we can not always answer. And my colleagues, they say this half-life is so long and it will stay in the bone forever. I think it's very difficult to restart it. And you have to avoid second ONG lesions because that can be the end of the life of the patient. But if she's suffering, we might have to look for other treatments like radiotherapy, surgery, but you have to discuss it multidisciplinary with all people, also the patient. Thank you.
Thank you.
Okay, and I think this question is highly challenging clinical dilemma, centering on the balancing the urgent need to control severe bone metastasis against the need to treat or not exacerbate ONJ. And also, I think the management principles requires close collaboration with MDT or a tighter strategy. And also, I think the ONJ staging is very important. I also talked about our Shanghai number 9 hospital. First, an oral and maxillofacial surgeon should determine the ONJ stage. They have the early stage, progressive stage, advanced stage, and management stage are different from early stages and other late stages. And also, I think the guiding practice is withhold BTAs and identify alternative therapies. And also, I think the bone, I think AIC or others, we can use other alternative treatment, such like the local therapy, and optimize the systemic anti-tumor treatment to avoid the second. Professor Never has said the second. I think nightmare. I think. Thank you, and also we go back to this topic. We will ask Professor Nemmer. Could you tell us?
So if we have a patient with early breast cancer, we no longer screen for metastatic lesions. In the past, all patients had a bone scan, a liver ultrasound, and a chest X-ray. Then we passed on to a CT, abdomen, and the chest. And now we follow the guidelines not to do staging in patients who have up to stage 2A, clinical stage 2A disease. Of course, if the patient has symptoms or if there is an elevated tumor marker that we still do in Leuven, in Belgium, then we go and look for metastatic lesions, and we are very likely to use MR whole body. If the patient is metastatic, let's say like in the liver, and she has no bone lesions, this is infrequent, but in ER positive, HER2 negative breast cancers, this is rare, but then we do, look with a CT scan to the bone. Sometimes we find these lesions because patients have had asymptomatic osteolytic bone lesions that become osteosclerotic when they have a CT scan for other diseases that we, by incidence find 25 bone lesions that have become sclerotic as a response to the anti-hormone treatment. So there are several ways. If we have a patient who has an elevated tumor marker and we have, a second opinion in Leuven, very likely that we find something with the whole body MR scan. So for us, this is the new way of detecting bone lesions. Yes. How to evaluate these patients? The tumor marker is very helpful if that is elevated, like this is the case in 75% of the ER-positive, HER2-negative stage 4 disease patients. If the tumor marker is normal, we do a 3-monthly assessment, and there it depends on the extraskeletal lesions, how we follow these patients, but very likely CT scan or whole body MRI. Yes.
Okay, thank you for your providing
May I ask how is
experience.
FAST-PET used in your diagnosis of bone metastasis? FAST-PET. FAST-PET, FES-PET.
Yes, we don't have that available. In the past, we could collaborate with the Netherlands, where in Groningen, about 500 kilometers from Leuven, they had such a fast PET, but we don't use it in the routine. I guess you don't use it either. But this is, of course, the future.
We
Yes.
don't have it now currently, but in Professor Zhang's hospital, yeah,
Oh,
it is available there. Yeah.
so
Yes.
you have a HER2 PET, you have a fast PET,
Yes.
you have a copy PET.
Yes, we have both of them, all of them. We have the FastPET we can use to test whether this is a bone metastasis, and also we know that the ER negative we cannot provide the information. However, when we the ER positive, we know this is a metastasis, and also we know that the ER positive and the heterogeneity we know that, and also we have the HER2 PET to test whether this is a metastasis. Thank you, Nevin and Professor Fan. And also, we mostly use CT scan, bone window to evaluate the efficacy of treatment for bone metastasis to differentiate whether between the osteoblastic or osteolytic lesions. I think it's very great. And then we'll move to the last question and last topic. And the last topic is patients with breast or prostate cancer often experience long-term survival. How to improve their long-term adherence to this therapy, and also, so Niven first, please.
So it depends, of course, if there is early stage, but I guess you mentioned metastatic disease. Indeed, we now have doubled the OS in patients with stage 4 ER-positive, HER2-negative disease. Because of the new drugs, we have CDK4/6 inhibitors, we have antibody drug conjugates in breast cancer. So treatment adherence is uppermost important. How to discuss this with the patient if she has bone mets to make her adherent to this 3-monthly zoledronic acid infusion or the monthly denosumab subcutaneous injection. We tell the patients how important it is. It's part of the treatment, like Professor Ying Fan mentioned. It's also depending on the treatment that you offer these patients, if it's chemotherapy, anti-hormone treatment. As Professor Stenzel said, sometimes it's triplet treatment, then there comes this bone target agents on top of that. It's not always easy, but you have to spend time. We have an onco nurse that sits with the patient explaining the importance, so this will improve adherence. And that's also one of the reasons that we have very long term survival in these patients.
It's great. What about this topic for Professor Stenzel?
Yeah, it's a very, very good question. Simple anti hormonal therapy with and LHRH agonist treatment is usually given. Now there are other possibilities, but it's usually given by subcutaneous, then 1, 2, or 3 months injections. 6 months and 12 months is available as well. That makes it a little bit easier because the patient doesn't have every day to take a certain drug. And it's usually I use in my practice almost exclusively 3 months injections, and that the patients usually adhere to that. Of course, the younger ones, they may have a problem. You may, after a certain time, we talked about it, think about the bone health and give 6 monthly injections for prevention of osteoporosis, which in male patients is not usually such a problem as in female patients. But again, these 6 months substitution may be helpful. When it gets to doublets and its side effects, then it gets a little bit more difficult. And we seldomly have doublet or triplet therapy that go beyond 2 or 3 years. Because then patients tend to progress and then we will have to change anyhow. And that patients tend to be motivated when they know that something is progressing in a problem. Then even male patients get disciplined. Other than that is we should not forget about exercise, mental health. That is something that gets more and more prominent now, and we have studies ongoing where we work with sports medicine departments at the university to work together and have a joint program with exercise including, and so that some of the side effects of anti-hormonal treatment cannot be seen as much. And that is diet. I wouldn't go into diet, but if then it should be done with a study. We've done it, and I think you're in a better area than we are in Central Europe with the diet, with your original diet. But we have seen that soybean derivatives like genistein and dadasein, we tried to did a study on that. We did not see a benefit in the early event of the disease, but that is something I would still study and see whether there can be any substitution really beneficial for the patient. Again, you are the specialist with soy diet, but that is something where we also had a comparative study between Western and Eastern diets. Of course, it's different now that with all the changes in both areas with diet, but that would be something that could be maybe helpful in the future, especially for prostate cancer patients. Thank you very much.
Okay, thank you for providing us a lot of methods to improve the long-term adherence, not for female, but also for the male patients. And also, Chinese professors, both of them are experts in breast cancer. And could you give a brief response to this question? First, Professor Fan Ying.
Okay. I think this is not a question or not a concern for bone target agents. It's a concern for all the other agents, hormone receptor treatment, the target agents. For me, if an agent want to have a good adherence, the treatment strategy must have several properties. First, it must be effective, so we can use it for quite a long time. Second, the toxicity or the side effect must be very tolerable or at least manageable under our guidance. Then second, a third, it must be easier to administer. So oral is more easier than injection, subcutaneous, either the injection 3 months, either the 1 month, something like that. And the fourth one, it must be not very expensive, so it can be affordable. So we don't want to make the patient out of the pocket under one treatment. And that's one I think is most important, is the communication with the patient. That's all. Thank you.
Okay, thank you for nice comments, Professor Fan Ying. So lastly, we will invite Professor Zheng Yingduo.
Okay, thank you. And I think the educate the patients is very important, and to make them realize the importance of the treatment. And the second one, and like Professor Fan said, for some patients, we should recommend for example, we should recommend some cheap and effective treatment for poor patients. And the third one is the adverse event can also it's very important. And if patients suffered from some adverse event, we should react quickly, and we should give them help to release these side effects. And I think I think if they feel comfortable, and they can receive the treatment longer. Thank you.
Good. Thank you for great comments. Okay, very well. All 4 topics are now be discussed. Thank you to Professor Niven, Professor Stenzel, Professor Fan, Professor Zheng for your insightful sharing. And time flyers, and the ESMO 2025 Chinese focus on the bone metastasis, ESMO 2025 Chinese Researchers' Voice to the World project is drawing to a close. Once again, we extend our gratitude to the conference organizer and Beijing for support. We hope this meeting will foster deeper academic exchanges between China and the international community in this field, and help